I
The
see.
B3s, you alluded to it. I think those are really challenging cases because you need to really pull out all the tricks for those. Uh, when you have massive amounts of bone loss, you've essentially got to either replace all that lost bone or reconstitute all that lost bone somehow in order to support your stem. Because if your stem's not supported, it can break or it can fail in some other mode. So B3s are pretty tricky. Thankfully, extremely rare. So you got a lot of options there. None of them are really good though. Uh, there's, you had alluded to these allograft prosthesis composites, which I think still, from a testing standpoint, I think still get tested.
Yeah.
I'd say these are exceptionally rare to see, but they're still things. So essentially, the implant is put into the bone already, and you've got to now implant that composite into the remnant femur, and hope and try to create a situation by which the bone of the allograft can integrate with the bone of the native femur. It's certainly an option. Thankfully, I think with modern implant design, we don't see it as much anymore. I think the next most common thing might be impaction grafting. This is also an exceptionally rare procedure, very technically demanding.
Can you
Hopefully, you guys don't
explain
have to
what
see
that
one.
is?
Yeah, yeah. So hopefully, you guys don't have to see one during residency. But impaction grafting, essentially, you have to try to recreate using usually some type of metal mesh, something that vaguely resembles the proximal femoral anatomy or a tube. And then what you do is you use a system to impact morselize cancellous bone very tightly into this mesh tube and what's remaining of the patient's proximal femoral bone. And you kind of do this over and over with various size impactors until you really get a very dense allograft, essentially tube in the proximal femur, and then you can cement a slip taper or smooth polished tapered stem into this new tube that you've made. The hope being that if you impact it tight enough, you give it some structure, but because it is cancellous bone, you can cement into it and give the implant some stability. Certainly, some of those can do really well, but the vast majority certainly have a bit of a short shelf life. So it's a usable technique. It's a great technique to have in your back pocket as an arthroplasty surgeon, but it's not one you want to go into the OR knowing you have to do. It's just very painful.
Sounds like it. Yeah, it doesn't
Takes a
sound
whole, it
fun
takes a
at
long
all.
time.
Yep.
Yeah, sounds
Doesn't.
rough.
Yeah, I never seen nothing like that. So
Me either.
uh, might be interesting to see maybe once or twice. Um,
Great fellas.
yeah, yeah. And so, when are you starting to think about like a proximal femur femoral replacement for these type patients as well?
Yeah, proximal femur replacements are really good, I think, in an older patient population, which are lower demand, which it looks like you put on there a slide, which is good. And often in situations where you've already lost any hope at having trochanteric bone or abductor function there, because you really don't have much of an opportunity to preserve abductor function in the setting of a proximal femur replacement. So massive proximal femoral bone loss with really no hopes of recreating any type of anatomy with various allograft techniques, whether that be with strut grafts, impaction grafting, allograft prosthesis composites. If all those are really off the table, or you have an older patient, you need to get him in and out of the OR in an expedited fashion, I think it's a reasonable surgery to do. Certainly carries the dislocation risk much higher than some of these other options, because without abductor function, you really lose that lateral restraint to dislocation. So just something to be aware of.
What
Okay.
about, just the thought that these patients are, I guess, what are your thoughts about this? Because you can try to do, possibly some kind of technique to not do this such a like a femoral replacement, but are these patients able to weight bear right off the surgery?
Yeah, that's a really great benefit to having a proximal femur replacement, is that you really don't have any restrictions. It's typically they're cemented, though there certainly are cementless options for these. But you can get them weight bearing as tolerated pretty much right away. And for kind of a low demand elderly patient where the risks to them are more associated with lying in bed, that's a great option.
Yeah,
Hmm.
yeah.
Yeah. And then I
Something I
guess
keep in mind. I know, like a lot of the questions, they like you say, they're always elderly. They try to give you that, and they're somewhat low demand. But a lot of times in the question, they're like 85 and up when when they want you to pick this answer.
yeah. to make it really clear.
Yep.
Yeah, and I think that's the hard part about some of these. When a questioning standpoint, I think you've got so many options, none of them which are really great. You hope that they try to lead you down a road where it's very clear that the bone stock is not adequate and you need to either replace it or do an impaction graft. But I think the key is to remember what you're trying to solve, and in this case, it's how do you minimize the risk to the patient, give them an adequate outcome, and minimize the risk. For an 85-year-old elderly patient, low demand, I think about them like I said before. If my hip fracture patient who comes in with femoral neck fracture is at risk from sitting in bed, so is my 85-year-old with a periprosthetic fracture. So my goal is to get him out of bed. If the only way to do that and get him walking is to get a proximal femur replacement, that's the answer.